and stuff like that. So it's pretty straightforward, easy material. There's a lot of pictures, a lot of redundancy, like typical, just to sort of reinforce concepts. So if you look at it like, holy crap, 94 slides in one, it's not that big a deal. Okay. So, any questions before we get started about anything we've covered so far? Anybody remember anything we've covered so far? Yes, right. What? So we'll talk some derm stuff. What section is this for derm? Huh? So is it like the cancer stuff?
Scabies.
Huh? Scabies. Okay. Oh, derm block too. Scabies. All right. What do you think? Yeah. Well, urgent consultation, right? Why fever? What's that? Yeah, it's an infection, either an infected stone, an infection behind the stone. So if you have kidney stones and a fever, that needs to go right urgently to get that ureteroscopy to get the stone out, okay, to clear that infection. Can't sit on that because it can get really bad pretty fast, okay? Everything else with the stone, A, C, D, and E, are all pretty routine things, okay? And the 5 millimeter stone size, yeah, that's getting towards the top end of when we might need an intervention. But again, what was the upper end of size that we can treat with medical therapy? You guys remember? 10, yeah, which is pretty big. But again, let the urologist make the details, so. So decreased stone formation, what do you think? I heard it already. Anybody else? Huh? E, thiazide diuretics. And what's the mechanism of that? Decrease urinary calcium, right? Decrease urinary calcium concentration. Okay. What would be the problem with doing Bravo? It would make it worse, right? It would make it worse. If they don't have calcium in the gut to absorb the oxalate, then that oxalate makes its way into the urinary system, and then that is the strongest stone promoter. So by going with a low calcium diet, it'll actually make things worse. Okay? All right. So today is going to be a big bucket of men's health topics. Okay? Because you don't really cover these topics much anywhere else, and really not everything in this lecture is necessarily urology per se, but everything in this is related to the urologist milieu, what they do. So that's why we put these all together as a generalized men's health lecture, okay? So most of the remainder of this will be men's health in nature till we get to the incontinence and fertility, but even then we'll be mostly focusing on the male patient side. Okay, so just remember penile anatomy, because it's important to understand the structures when we start to talk about things like Peyronie disease, where that fibrous plaque is starting to form. When we talk about erectile dysfunction, where the dysfunction is occurring. There are traumatic events that can happen to the penile anatomy, including a penile fracture. Okay, and that is a disruption, a traumatic disruption of the membrane called the tunica albuginea that covers the outside of the cavernous bodies, so that essentially what contributes to the rigidity of the penis of an erect penis, excuse me. So if you have an acute disruption of that, you have the inability now to maintain erectile physiology, so there are real serious consequences to trauma to the penis, okay? And then obviously, we're going to talk quite a bit about the prostatic urethra, because what do you think the problem of the prostatic urethra is? BPH, right? That we start to have this inward, aggression into the urethra, and then that patient starts to experience difficulty with urination, obstructive urinary symptoms. So this is the structure, right? We talk about erectile physiology. This is what becomes engorged with blood. But this tunica albuginea, white tunic, right? fibrous coating that encapsulates those bodies, if you will, and maintains the rigidity of the penis. So if that is disrupted through trauma or some other mechanism, then that patient will lose blood and then lose the ability to maintain an erection, and then subsequent to that, may start to develop abnormal curvatures. And when we talk about things like that, when we talk about like erectile dysfunction, we talk about trauma to the penis and stuff like that, you know, the jokes write themselves, guys. I get it. You know, we can chuckle and chortle, but seriously, when you start to think about quality of life and the ability to have sex or not have sex based on an injury or an abnormal curvature of the penis or painful erection, the inability to attain or sustain an erection, it is a really, really big quality of life issue. So being able to take care of that for our patients, being able to return that normality to their life is a really big deal. So again, I will be a little bit tongue-in-cheek up here, make a few off-color jokes, but in our clinical practice, keep the poker face on, okay? So let's get started with some derm stuff, all right? Balanitis, balanopsitis, so these are both conditions of infection, usually fungal infection, and this is something that happens to balanopsitis only in an uncircumcised man, right, of the penis and the foreskin, all right? So what happens a lot, and you'll see this, you know, during field problems, if you go on deployments, things like that, most commonly where hygiene isn't as meticulous as it may be sometimes back in the rear, you can get these fungal infections. And where do fungus like to grow? Warm, dark, moist places, which is what it's like under the foreskin, right? And so it has a predilection to grow there, especially if the patient is not being really meticulous with cleaning under the foreskin. These can grow. And the reason why this is important is not necessarily, I mean, it's a fungal infection, it'll go away. Unless this patient is really immunocompromised, it's not that big a deal. But what happens is the inflammation subsequent to this can lead to a condition that we're going to talk to called phimosis or paraphimosis, okay? So either the foreskin can no longer be retracted over the glans penis, or if it is retracted, it can no longer be returned to its normal position, meaning it has a tourniquet-like effect. So we'll talk about those in a minute. But the chronic inflammation of these conditions can lead to that. And also, these conditions, if the patient has them chronically over and over again because of hygiene or just because it just happens to this patient, we can send them to get a elective circumcision, or if as an adult. And I've had to do that for some patients because it just keeps happening, even despite their best efforts, okay? So, Candida, so what do you think we use for it? Antifungal, right? Clotrimazole, right? You could give them diflucan if they just want to take a pill. But you see the difference is just red, bumpy, irritated, it looks like a fungal infection, right? It really doesn't, differential diagnosis-wise, there's not a whole lot that masks, right? If it has this sort of white, sort of caseous material, and it really even gives it a little bit more clinical obviousness, I guess you could say. So, what do we need to do for laboratory tests? Honestly, I know this is a long list. In your average run-of-the-mill patient, do you think we really need to get these tests? Do we need to go down this rabbit hole for a fungal skin infection? No, not at all. You don't really need labs, all right? It's pretty much an obvious diagnosis in most cases. If it's not, then of course you can KOH it and see if you have fungal elements. You can swab it if you think there's some sort of confusion that it might be a herpes lesion. But in most cases, this is a really obvious clinical diagnosis, and you just treat presumptively, okay? And the biggest thing for this, again, is patient education about cleanliness and hygiene, not only washing, but also drying, because it is sometimes the moisture that contributes to this more than anything else, okay? So, hygiene, soap and water, right? And then clotrimazole or diflucan, fluconazole, right? Have you guys talked about those meds, I'm sure? So, it's most often not bacterial, and you don't want to add steroids to it because you can make it worse, obviously, okay? Urologic consultation, as I said, if this is a chronic problem, this patient just keeps having recurrent episodes, then go ahead and send them to talk to the surgeon about potentially an elective circumcision. Okay, easy. Phimosis now, getting a little bit more serious. They're going to, again, like I said, they're going to be contrasting conditions here. They sound similar, phimosis and then paraphimosis. One is no big deal. This one, not really that big of a deal. The other one, more like an emergency. An urgency, at least, okay? Now with phimosis, obviously the foreskin cannot be withdrawn over the glans penis, so that hygiene becomes even more difficult. This patient who experiences this is likely to experience those balanitis conditions, okay? So just understand that. But as long as the patient is meticulous about their hygiene, I keep using that same phrase, meticulous about the hygiene, then, you know, it's really not that big a deal. So if the patient if it's uncomfortable, which it usually isn't, if it leads to other problems, then we might go to circumcision, but circumcision is not mandatory in this case. It would be more of an elective thing unless one of the sequelae occurs. Make sense? Pretty straightforward. But again, it's just an uncircumcised penis can't be withdrawn over the foreskin, okay? And depending on the degree of it, treatment might be indicated otherwise. The one thing is that those chronic yeast infections or that chronic sort of dark, moist region, thankfully, sorry, I'm losing my train of thought. Thankfully, cancer of the penis is not common, but if it does form, it's usually squamous cell carcinoma. And of course, with that foreskin not able to be moved easily, it's hard to sort of inspect that area, do a full dermatological exam. So sometimes that kind of cancer can form and not really form a lot of symptoms or manifest a lot of symptoms until it's pretty late, okay? So higher risk of squamous cell carcinoma of the penis, even though it's a really low incidence cancer, okay? So now paraphimosis, this is an emergency, right? So now we have a glans penis that is trapped, or excuse me, foreskin that is trapped behind the glans penis. And what is the physiology that's essentially happening now? It's like a tourniquet-like effect, all right? So this becomes an emergency. This becomes something that needs to be addressed. And there are multiple different ways to try to address this, and some of them are hilarious in their explanation. So I'll let you know. But basically, it could be because of a balanitis or balanopsitis. It could be a phimosis that actually, I'll say this tongue in cheek, but literally popped through, made its way through, and now it cannot return. And so again, you have ischemia happening at the tip of the penis, and that is an urgency. That is an emergency because that is a tissue-threatening injury, right? So we can't let that go. That is an urgent urological referral. So multiple different ways this can be treated. One of them is literally to try to reduce the inflammation, like just hold the end of it and try to force the head of the penis back through, like literally try to pop it back through. You can use ice packs. You can try to disengorge it with needle decompression, which usually almost never works. You can do a scissor snip incision after you do a penile block, but that is a last resort. And if you don't have to do that, this is not something that you should do in the emergency room. If you have care available or transport to urologic care available, there's no reason to do that unless you think that this patient is already losing tissue. But really what this patient needs is what? Circumcision. Yes, a circumcision. And they need a circumcision regardless, even if manual reduction is successful, this patient still needs a circumcision because if it happens once, it's likely to happen again, right? So we don't want to risk it. And the next time it happens, the patient might not be somewhere where care is readily available. And again, time is tissue, so we don't want to lose that, obviously. Okay? Any questions there? So contrasting, right? Phimosis, not really that big a deal. Paraphimosis, a very big deal in emergency, a tissue-threatening injury. Okay? Penile fracture, I will tell you it is usually something that happens during sexual intercourse. It is usually a sex-related injury. Okay, you can use your imagination of what that means, but it is a sudden, this patient will feel a sudden pop, and then all of a sudden they will have a huge disengorgement of the erection, and that blood is just leaking out around the cavernous body. That is literally called eggplant sign, aubergine sign. Aubergine means eggplant in French, so now you know a French word. But all hilariousness aside, that is a life-altering injury potential. Because if that is not treated immediately, but with a correction of that tunica albuginea, this patient may lose erectile physiology. They may develop a serious, painful curvature of the penis if it just fibroses down, which is Peyronie's disease. But I mean, some of these Peyronie's disease can be at extreme angles. I'll show you one coming up. But men, understand, urgency. Urgency needs to get this person to urology to fix that, or else this patient will have serious life-altering consequences, okay? So, any questions so far? So a couple of emergency things, a couple of non-emergency things, working our way down the line, okay? That's a good way to bucket these. What do we need to address immediately, and what can we sort of like treat on our own, okay? Hypospadias and epispadias. Have you visited this in peds at all? Yeah, okay. So basically just a malformation, or a malplacement, I should say, of the urethral meatus. And clearly this is something that would happen after birth, you know, that you would be identified after birth on well baby visits immediately after the patient is born, all right? The degree of hypospadias can be anywhere from just, you know, slightly displaced at the tip of the penis to all the way down in the perineum, okay? Usually the deformity of hypospadias is just that, just a malplacement of the urethral meatus, whereas the deformity of epispadias is usually much more dramatic, meaning a much larger opening, usually not congruent with any kind of urinary continence, and needing to be surgically replaced much, much sooner. Hypospadias, if the patient's parents are electing to have the patient circumcised, in most cases they will delay that circumcision until they can have the hypospadias addressed, because they can actually use that skin from the circumcision as a graft and then create the hole where it's supposed to be, create the urethral meatus where it actually is supposed to be, okay? So, good prognosis over here, bad prognosis on this side. Just understanding, the hardest thing about this is just understanding which one's ventral, which one's dorsal. So hypo underneath, epi above. That's the easiest way to remember it, okay? And again, the displacement, and you might actually run into some of these patients who do have hypospadias who have never had it corrected, because it's just a very slight, malplacement, right? It's just a very slight, ventral displacement of the urethral meatus. If you see it on physical exam, you can ask the patient about it, comment on it, and as long as it doesn't cause them any pain or problem or urinary continence issues, there's nothing to do about it. It's no big deal, okay? Versus epispadias, which you usually will not walk in as an adult, because again, very dramatic defect that is clearly not something that that patient will be able to maintain any type of urinary continence, okay? Core D, just a brief note about this one. It's sometimes associated as not just a hypospadias, but also a true shortening of the urethra. So this would be a surgical fix, of course. But again, just an atypical presentation, just something for your GWiz memory banks. Not that common. Okay. Questions so far? Too fast? Good. We good? Okay. You guys didn't have a test today, right? All right, cool. All right, Peyronie's disease. You will see this. It is becoming more prevalent for some reason. And your patients who watch TV will have heard of a website called, and I shit you not, bentcarrot.com. Okay, it is for, and you know why they do that? I should go into marketing. It's the same reason with that stupid picture like I made of The Rock. It's because bentcarrot.com, you're not going to forget that. You know what I mean? It's pharmaceutical marketing, and it's for a drug that is directly FDA approved for Peyronie's disease. Okay, and what Peyronie's disease is, why they call it bent carrot, is because it is a fibrous plaque that forms in the tunica albuginea somewhere, and that plaque serves as a pivot point, a turning point. When the patient when the patient has an erection, the penis curves in a certain direction towards that fibrous plaque. And that can be a very, very dramatic curvature, which can be incongruent with sexual intercourse of any type. It can also be extremely painful for the patient, okay? So what we're talking about, again, is a big quality of life issue. Like the inability to have sex, right, is not a small deal for anybody. So this is a serious problem for these patients, and usually it's idiopathic. Sometimes it's due to something like that penile fracture I showed you, but most of the time, this plaque just forms for no particular reason. You remember Dupuytren's contracture? That fibrotic plaque in your hand? Those are associated conditions. Sometimes patient will have both. Okay, if they have one, they may be more likely to have another. So if you look at that, clearly one maybe not too bad. The other one, you see that's essentially a 90-degree angle. Very painful. Patient can't have sex. It affects them, their partner, their entire life, right? So understand that it's not, like I said, bencarrot.com, you can chuckle a little bit, but this is a serious deal for your patient. And as far as physical exam goes, what the patient will complain of is painful erections, okay? Painful curved erection. When their penis is flaccid, when they're non-erect, they don't have any pain, they don't have any curvature, anything like that. It just becomes when that expands, when those cavernous bodies expand, it hits that pivot point and it turns, essentially, is what it is. So physical exam-wise, you may be able to appreciate the plaque, like by palpation. This is one of the real only indications to do like a true palpation of a patient's penis. Most of the time, it's just an observation, looking for skin stuff or just malplacement of the meatus, anything like that. If you have a patient you suspect has Peyronie's disease, you might try to palpate the plaque, but honestly, what do you think this patient really needs? Ultrasound. Ultrasound to identify that plaque. And honestly, if they do proceed to surgery, I've heard somebody say surgery, if they do proceed to surgical intervention, which is kind of a last resort, sometimes they will give this patient a medication called alprastatal to induce a pharmacological erection in clinic to actually see and define the location of the plaque and the degree of curvature. So it's actually a surgical planning tool to see how bad it is and understand how much tissue needs to be removed, how much fibrous tissue needs to be removed. But let's go back to the genesis of it. Most of the time, the patient will begin the process of Peyronie's disease or begin the pathophysiology of Peyronie's disease idiopathically. Nothing really happened. All of a sudden, they just start to have painful erections, right? And the pain may precede the curvature, right? So painful erection, then they start to note an abnormal curvature. As it proceeds, the curvature may increase in angulation, if you will, but the pain starts to subside, okay? In general, sometimes the patient has pain throughout, but in general, that's the way it sort of manifests. Pain, angulation gets worse, pain sort of resolves a little bit, okay? And then, like a physical exam, you may be able to appreciate this fibrous plaque and the tunica albuginea. And that's why I pointed out at the beginning that tunica albuginea is extremely important when it comes to erectile physiology. It's essentially what maintains the rigidity of the erection, what holds the blood in those paired cavernous bodies, okay? And again, physical exam-wise, maybe not. Ultimately, ultrasound is going to be your friend here. And again, Dupuytren's contracture, sometimes in association. Treatment, this is the medicine that you will find if you go to bencarrot.com. XIAFLEX is the trade name. All right, now let me tell you something about everything on here. Who do you think is doing all of these things? Yes, not primary care. That's right. If you have a Peyronie's disease patient, they should go to urology. Now, does that mean urology is going to keep them, hold them, and manage them entirely? No, they may start them on a medication, and then who follows them up? Primary care. But you will not be doing this. Do not stick needles in people if you don't need to. Okay? So send them to urology. If they need these injections, urologists will do it. In fact, XIAFLEX, I would not imagine, unless you are a urological PA, would even be on your formulary, okay? So send them, that's the domain. And then again, that surgery right there is not super great. as you can imagine, and it's really a last resort, okay? But ultimately, after all of that said and done, it's a lot of background on Peyronie's disease. What's going to happen? Patient's going to come to you and say, it hurts when I get an erection and it's bent. What do? Physical exam and refer, okay? That's Peyronie's disease in primary care, simplified, all right? Priapism, you guys talked about this anywhere else yet?
Yeah.
Talk about a neuro a little bit, maybe? Neurologic injury, sometimes. Farm, okay? So this used to be, like back in the day when Viagra was first coming out, this would be the most popular of the side effects for PDE5 inhibitors. If you have an erection less than longer than 4 hours, visit your doctor. That's the definition of priapism, longer than 4 hours. Just so you know, that's actually one of the, if not the least common side effect of PDE5 inhibitors. They're incredibly safe. Priapism is pretty rare with those medications. All right. Most of the time, if it's a medication-induced priapism, it's cocaine. Okay, just so you know. 2 different types here, and it's really important to understand this, but it's also pretty obvious when I show you the clinical symptoms. Ischemic and non-ischemic. So which one do you think is worse? Ischemic. Yeah, usually that's bad, right? All right. So, did you mention this in sickle cell anemia? Those sickle cells can get stuck in a lot of places, especially in that microvasculature, and that could be a cause of a priapism. Very painful erection. That would be an ischemic one. Let's see. Cocaine, alcohol, sorry, everybody. But infection's much less likely. Spinal cord trauma, but really, if we're talking about trauma, traumatic priapism is usually non-ischemic in nature, so non-painful and not as threatening to the erectile physiology. So this is another emergency, all right? Urgency/emergency. You do have time here, right? But it is something that needs to be treated urgently. I know that bridge between what is urgent and what is emergent is very gray, but you understand what I'm saying. This is something that needs to be addressed, okay? So this is usually due to trauma, not fully. So do you guys know, are you guys familiar with the word tumescence? Tumescence is the degree of rigidity of the erection, okay? So when it says a partially tumescent or detumescence is the loss of the erection, the return to normal. Typically a partial erection are non-ischemic, so not as rigid, all right, not usually painful, and erectile physiology usually spared, so that's good. You usually treat the issue, like it's usually a sequela of something else, so you don't necessarily have to treat this as urgently as you do ischemic, which is much, much different. And that's why I highlight this one. You guys are familiar with compartment syndrome, I assume? Okay, so this is Lichen compartment syndrome. This is the painful erection that lasts longer than 4 hours, being the definition again of what is priapism. Okay. Physiologic obstruction of the venous drainage, right? So what does that mean? It means you have old deoxygenated blood sitting in that tissue, not being able to be released and not being able to be refreshed, so that tissue is losing oxygen, it's becoming ischemic. That's why it's called ischemic priapism, right? And then treatment here is going to be a needle, actually, all right? So multiple needles probably. So why phenylephrine? You guys remember your sympathetic, parasympathetic nervous system? Right, adrenergic agent, right? So what type of physiology is an erection? It's our feed or breed, right? Or rest or digest or whatever the hell you want to say, right? So in order to counteract that, adrenergic agents kick on the sympathetic side, hopefully detumesce, right? So you can do instillations of phenylephrine. But let's go, I'll go to the treatment here in a minute. This is, again, like I said, there's going to be a lot of charts here. This is used for just side by side. But again, if you just think ischemic versus non-ischemic, which one's worse? Ischemia is worse than non-ischemia, okay? The other thing that's on here you have probably not seen before is abnormal penile blood gas, all right? Now, I'm not going to ask you to do interpretations of penile blood gas. That's for when you get into clinic. But you will literally have to evacuate the blood and send that to the lab, and that is part of the treatment as well. So it's diagnostic and therapeutic. You have to, if the patient does not need tumescing, you have to get the blood out. All right, you have to save the tissue. Again, this is an erectile function threatening injury. So again, not something that is benign in any sense of the word. Okay. This one, let me explain what this one means since we haven't done erectile dysfunction yet. Intercorporeal ejection. What is wrong with me today? Jeez. Intercorporeal injection. So, when I said that in the office you can give a medicine called alprostadil to induce a pharmacological erection, that they might use as a surgical planning tool for Peyronie disease. Well, that can also be prescribed to patients who have failed oral PDE5 inhibitors, right? So one of the erectile dysfunction treatments is intercorporeal injections, self-administered prior to intercourse. That has the risk of priapism, a little bit higher of a risk than PDE5 inhibitors do, okay? So that's what that means. This patient may be prescribed that alprostadil medication, and they may have just given it to themselves, and now they've induced a priapism, right? Everything else here, and then the hematologic abnormality, sickle, right? That's usually with sickle cell. Could be something else weird like erythrocytosis, but usually that hematologic abnormality is going to be either one, cancer, or bone cancer, or two, sickle cell anemia. All right. Any questions so far? Besides my stumbling over words today for some reason. All right. So yes, see the color of this blood. Right. It's evacuation of the blood. All right. Aspiration of the blood, send that blood off for blood gas, and then installation of phenylephrine and saline to try to literally wash the area out and induce detumescence. All right. Now, what happens if that doesn't occur? This can proceed to surgery, but that usually doesn't happen, of course, and it is a last resort. All right. But again, this is a procedure that you can do in the emergency room if you don't have urologic care. Now, if you're working somewhere like BAMC, where urology is on call, then call them. Okay, but if you're not, then this is something that you can do as an emergency room provider, all right? So just understand that this is, and priapism is something that you'll see on a, I mean, once in a while basis, but it's not a zebra by any stretch of the imagination, okay? Any questions? Now, penile cancer again. Risk factors, unusually squamous cell carcinoma, uncircumcised or HPV are big risk factors. So another reason to recommend Gardasil. Squamous cell carcinoma, have you guys, so where, you haven't done the cancer block then, the skin cancer block? Okay, well then this is to be a preview. Basically these are just different degrees of squamous cell carcinoma. Erythroplasia of Barrett looks like this sort of like velvety red lesion here. Bowen's disease is true. Cancer in situ, you guys know what in situ means? It hasn't spread yet, hasn't moved, so it's there, it hasn't penetrated the deeper layer. And then precursors all to frank squamous cell carcinoma. All right, so again, why is this important? If you're doing examinations on your patients and they are circumcised, have them withdraw the foreskin so you can examine all of their skin. It's really important. Cancer forms in the most unlikely of places. You guys know what killed Bob Marley? Melanoma on his foot, right? So you got to look at all the places. You got to look in the perineum. You got to look at the labia. You got to look under the foreskin, all right? You got to look at all the places because cancer forms anywhere. And if you're not looking for it, you're not going to find it, and then your patient is going to have a bad outcome, okay? And then treatment for cancer is send them to the cancer doctor, of course. Okay. Urethral stricture. Now, this is going to be one that's kind of confounded with BPH quite a bit, but here's the story that typically is urethral stricture. It's a younger patient, somebody who doesn't fit the age demographic of typical BPH, right? So what do I mean? Younger men, typically. Younger men. And not just men, but more commonly in men. And what the reason is commonly is the last one. Think of a patient, sort of a prototype here, of a younger man who has had frequent urethritis infections, frequent gonorrhea, chlamydia, mycoplasma genitalium, ureaplasma infections, and that has caused inflammation, and inflammation has led to some fibrosis and narrowing of the urethra. So they're going to have obstructive urinary symptoms, right? Decreased frequency of, or decreased force of stream, like they feel like they have to bear down to get their urine out, some post-void dribbling, and then some just weakness of stream, like urinary frequency, like double void, going to the bathroom, then feeling like they have to go again suddenly because they weren't able to get everything out. So again, think of the younger man with obstructive symptoms. Doesn't really fit the BPH picture, then think urethral stricture. And this is our prototype. In the treatment, really, is going to be up to urologists. They'll do a cystoscopy to determine the degree of the stricturing, and then what's necessary. It can just be a balloon dilation, like break apart the fibrosis and open the pathway back up. Okay? Questions about any of that stuff? Pretty straightforward. I mean, none of that is rocket surgery. And we'll talk about testicular masses. Okay? I'm going to say this now, and it's in the slides 15 different times, and it's also in other slides where we talk about testicular cancer. But a testicular mass gets an ultrasound. Okay? AUA says ultrasound should be considered an extension of the physical examination, right? So whereas in ortho, you're like, you should do it, all your physical exams should tell you why you need an MRI. In urology, we're going to use the radiographs as part of our physical exam. And why? Because do you want to be 99% sure you don't have cancer? Or 100% sure? Right? You see what I mean? And there's going to be physical and clinical clues that's going to tell you, oh, in your mind, 100% there's no way this is cancer. That still needs to get an ultrasound. Does that make sense? So we're going to start from that and work our way up to it. You guys want me to close this door? Is it too loud? Yeah? All right. Shut up out there. All right. All right. So, important structures here, okay, in the spermatic cord. Important to know what's in the spermatic cord. Things that we are looking at are hampeniform plexus of testicular veins. Can anybody tell me what the pathology that forms there is? Varicocele. All right, and then of course our vas deferens is important there. And that's pretty much it. Everything else is just nuts. But those are the things that really form a lot of our pathology. You can have, it's important to do a good examination on the spermatic cord, especially if a patient has infertility issues, because there is a condition called congenital bilateral absence of the vas deferens, meaning the patient may have been born without vas deferens. So if you can't appreciate that in the spermatic cord, what it feels like, you guys know like the old Bic pens that were clear and had like the ink inside? It's about like that in consistency and size. Like it feels firm and really small in diameter, but you can actually appreciate it distinct in the spermatic cord. And if you can't feel that, now clearly you're going to get an ultrasound, but that is a part of a good physical exam to make sure the patient does have vas deferens present. Okay? As far as other things that are weird, the appendix of the testes can torse itself, in addition to the actual testicular torsion, which we'll talk about in much more depth. The epididymis, posterior kind of comma-shaped thing on the back of the testes, right? Important again to make sure you're doing a good physical exam and distinctly feeling the epididymis, and then contiguous with the vas deferens up into the spermatic cord and palpating the remainder of the spermatic cord. Okay? You guys will do this in the RTA lab. You'll have male and female patients. You'll practice external genital exams, so you'll practice this. The best way that I can describe it to students is like you're sort of holding a hard-boiled egg, right? You're palpating it with the pads of your fingers and appreciating the entire organ. Don't get in there to the patient exam room and do a very cursory exam because you're uncomfortable or you feel weird about it. Appreciate the entire organ, appreciate the vas deferens up through the spermatic cord. You need to appreciate the whole thing, and the reason I harp on that a lot is because testicular cancer is a young man's cancer. I would be very surprised if almost every one of you didn't diagnose a patient with testicular cancer during your career. Since I've been here in school, 4 of our students have been diagnosed with testicular cancer, all right? So just understand that it is a young person's cancer. This is something that you will see. So good physical examination is of utmost importance, all right? If you go in there, you do a cursory exam, or you just pencil whip it because it's your buddy and you don't feel like looking at his balls, then you're not doing anybody any favors and you're gonna miss something that's very, very critical, all right? Let's see, yeah, we know that. Transillumination, we'll talk about that. Does anybody know what that pathology is before we get to it? Hydrocele, yep, hydrocele. We'll talk about that in peds then, I guess? Okay. Yeah, most of the time, a lot of people have a reactive hydrocele after birth, they'll usually form. You can also have a reactive hydrocele with a testicular torsion, or sometimes they just form later. Patient will have a patent, what's called processus vaginalis, where peritoneal fluid can actually come and form a hydrocele around the testicle, and that can cause a lot of problems and irritation of the nerves and cause the patient a lot of pain. Okay? Let me explain this one. So, why are patients coming in for testicular masses? They were taking a shower, they were doing a self-testicular exam, they felt something, they felt a lump, and they come in. Most of the time, when guys have something going on their testicles, they will be pretty quick to seek care, all right? And always take that seriously, and like I said, whatever it is, despite your physical exam and your clinical intuition, even if you're 99.9% sure, you will get an ultrasound. Whether it is confined to the testicle or on top of it. Now, let me explain what I mean there. Most of the malignancies will be arising from the organ itself, so growing from the inside out. It'll feel like it's attached to the testicle. It'll be immobile and firm and typically painless, okay? So it'll feel like it's, does everybody understand what I'm going to say? Coming from the substance of the testicle, not something that feels like it's on top of it. Again, imagine the egg, imagine a hard-boiled egg, right? Something's growing inside out, it's a hard fixed mass versus like something that's just on top of it that is fairly mobile, maybe even a little bit painful, okay? Usually pain is a good sign. Pain is typically reassuring when it comes to cancer, especially testicular masses, because again, those testicular cancers are typically painless, but hard, fixed, coming from inside the testicle versus outside on the top surface area. Does that make sense to everybody? And again, another reason to understand how to do a good physical exam and determine the testicle itself and the epididymis, 2 distinct things, okay? So this is what I just said. I told you this one gets redundant because I really want to make this point to y'all, that it's really important. I know we're coming up on break time, like 15 more minutes, right? 10 minutes. What is it now? 15 minutes?
Yes, sir.
Just wave your hand when it's time. I can't keep track of time. So again, as I said, malignancies, painless, right? So a patient comes in, they say they have a lesion on their testicle, they say it is painful. A lot of times that is enough to be reassuring to the patient. Even though it sounds weird to them, it is reassuring to us, okay? And ultrasound. See? This whole red box is the 99% thing. If it was you, would you want to be 99% sure you don't have cancer? Nope, you want to be 100% sure, right? All right. So, go down these. We're not going to talk too much about hernia because you guys cover that in general surgery a lot more. It's not really a urological problem, except in the fact that one of the types of hernias can make its way into the scrotal sac. Still not a urologist's problem. So we just cover it very, very briefly. Cover it more in depth in surgery, okay? So a hydrocele, peritoneal fluid, like I said, patent process. I'm going to switch slides real fast and I'm going to come back to this. But essentially what happens is you have this process vaginalis that is supposed to fuse in utero or shortly thereafter. If it remains open, then basically what you have is a pathway for peritoneal fluid to leak down and around the testicle on the tunica vaginalis, which is another covering of the testicle. And over time, it becomes engorged, right? And then essentially what happens, the symptomology of this one, is that the patient experiences a heaviness, a pressure, sort of an irritation of the nerve. The literal weight of all of that pulling down on that side of the testicle, on the spermatic cord, causes irritation and sort of a general dull, achy pain. Usually works with exercise. It's a very similar presentation as far as symptoms to varicocele, which we'll talk about in a little bit here. Okay. Another reason why even something as simple, like you're going to look at this, you're going to see it, you're going to know what it is. It's going to confound your physical exam because you're going to have this huge sac of peritoneal fluid, so you're not going to be able to do a good testicular exam. That's why we always get ultrasounds, just because another reason that this can be caused is a reactive hydrocele due to a testicular tumor that you might not be able to palpate because of that fluid. Does that see what I'm saying? Always get an ultrasound. All right. So you'll see them. You'll see them in babies. You'll see them in your patients. All right. They can be remarkably large, but luckily unless they are due to a malignant process, that itself, the hydrocele itself, is entirely benign. Okay. You usually try to treat medically first, especially if it's small and it's not causing your patient a lot of problems. Okay. So scrotal support, and when I say scrotal support, I mean like tight undergarments, right? Something that holds the scrotal sac closer to the body so that irritation of the nerve is reduced. All right. Ice packs, heat packs, whatever helps, the patient. NSAIDs are our friend here for most of these, seals, varicocele, hydrocele, just to help with the pain and irritation. And if the patient doesn't get better, or if you're not making an improvement, and they come back and say, like, doc, this isn't doing anything for me, just send them on and let them be evaluated by the urologist for surgery. Do not stick a needle into it, okay? There's no reason to go sticking a needle into your patient's scrotums, right? Especially if you have consultants available, okay? And as I said, this is not an emergency, okay? So there's no reason to do that. This one is going to be one of the things that most of you are going to see on a regular basis, and all of your patients who have these are going to think they have testicular cancer. This is going to be one of your most common testicular masses discovered by the patient. All right? Epididymal head cyst, so you know where it is, the head of the epididymis. Right? So it's sort of the top back of the testicle. The patient will be doing an exam or showering, whatever, and they'll feel this hard lump, and they will come to your office. It is just a small cyst of seminal fluid, okay? It is completely benign. What it feels like, I said, is like a hard, like BB. It is mobile, you can move it around. It's slightly tender, right? So it has all of the characteristics of a benign thing, right? It's mobile, it's slightly painful, it's on top of the testicle, not inside it. But what are we gonna do? Get an ultrasound. Good, see? That's what we need to do. We need to be 100% sure that that's all it is. Okay? And when we find out that's all it is, what happens to it? It typically regresses on its own, goes away, no big deal, right? If it's really symptomatic, like it's causing your patient a decent amount of pain, NSAIDs, same sort of like general treatment protocols, but this isn't something that would be indicated any type of surgical correction, anything like that. It's entirely benign. Now, size-wise, why do I put less than 2 centimeters? Because its bigger brother is a spermatocele, okay? This one is usually more symptomatic just based on the size. Sometimes these will form after a vasectomy, okay, because then the fluid has nowhere to go, so sometimes it does form a reactive spermatocele. Those do also typically regress on their own as well, excuse me. But again, this one is not, even though it's larger in size, it's filled with a more dense fluid. It's not usually going to transilluminate readily. So it might look a little bit like a hydrocele, but it's not going to be as easy to shine the light through it. And what we really need to do here, same kind of thing. say you have a same area, just a bigger mass, okay? And get your ultrasound, try to medically treat it, scrotal support, ice, NSAIDs, again, same. And then if it doesn't get better, doesn't go away, or gets worse, of course, send them on, excuse me, this one could be removed surgically. Right? This would be a potential surgical removal. Any questions so far? Now this one is important. You'll see this a lot. So why don't we take a break now so I don't have to stop in the middle of the varicocele stuff, and we'll see you guys in a little bit, okay? Okay, so varicocele, common, you're going to see this a lot. All right, this is going to be a common complaint that you'll see sick call your patients in primary care coming in with a complaint generally of a dull achy sensation in their testicles and their lower abdomen. Usually that's worse with exercise like running or lifting weights, just because of the increase in abdominal pressure. It makes the symptoms typically worse. All right, so it is a dilation of that pampiniform plexus, that sort of spider webbing of veins that are in the spermatic cord that drain the testicles back into the venous circulation, okay? What the classic, you guys have probably heard it at this point, the bag of worms on palpation, it feels like that's literally what it feels like. And they can be pretty dramatic, but they can also be very kind of almost clinically silent or clinically invisible, meaning you can't palpate them, you can't see them, but the patient is having symptoms that are very consistent with them. So if you're doing a physical exam and you can't appreciate anything, you can have the patient bear down or Valsalva. Sometimes it'll engorge the veins enough to make it clinically apparent, so you can actually palpate the vessels. Okay. So let's just talk about some pathophysiology here before we go through it, just to see like a thought experiment. What is the function physiologically of the scrotum? To hold the testicles away from the body, and why? Temperature for spermatogenesis, right? What do you think might happen if you have this big, heavy mass of hot blood vessels sitting on top of that testicle? And it will affect spermatogenesis, yeah? And so one of the common sequelae of an untreated varicocele is infertility. So we'll talk about this again in our infertility lecture, but if you have a male patient coming to you saying, I'm having difficulty achieving a pregnancy, this should be one of the first things you think of and look for on physical examination, okay? Now, back to more anatomy, and this is important. And this will be a question on the test. You guys, I don't know, this is my last urology class before I transition fully into APP and teach anatomy and physiology too, all right? So this is my last hurrah here in the senior semester. This has not ever been a 100% question, even though every year for the past 5 years I have told students that this question is going to be on the exam. And when you read the blue box information, you're going to see me in all capital letters say, I told you this question was going to be on the exam. All right, so please prove me wrong. I would love to see it. I would love to go out with this being a 100% question because it's an important concept. All right, physiology, anatomy, okay? When the left side, start with the left, when the left side spermatic veins drain, they go into the renal vein, okay, which is a relatively small vein when you compare it to like the vena cava, right? Relatively small vein, I'm sure. Maybe the red isn't the best color to use here, but right there, okay, where the big black arrow is. So what that means is on the left side it has to go up, take a relative turn, and then go into the renal vein and then into the vena cava, okay? So the pathway for blood flow is slightly more obstructed on the left side, okay? So commonly we will get varicoceles on the left side because of that relative obstructive pathway. And it's expected, and it's more benign in nature. On the right side, however, what happens is those veins from the testes and the spermatic cord dump directly into the vena cava, okay? So they go from a very, very tiny vessel into the second largest vein in our body, which means there should be no obstruction to that venous return, right? That pathway should be direct. So if something is obstructing our blood on the right side, that is uncommon, especially if it's a unilateral right side varicocele. And so what we go looking for is some sort of retroperitoneal mass, something that's pushing in the belly that doesn't belong there. What does that mean? That means we need to get a CT scan of the belly. Does everybody understand what I just said? Left side has to go into the renal vein, take a turn, then to the IVC. Left-sided varicoceles, not really a big deal other than the symptoms they cause the patient. Right-sided varicoceles, especially if they're unilateral right-sided varicoceles, often, or now I won't even say often because that's not even true, but are more likely to be associated with some retroperitoneal pathology, and so we need to look for it and make sure it's not there. Does that make sense? Does it make sense? Right-sided varicocele, bad. Okay? All right. Here's another picture of it. Okay? Right-sided varicocele bad. Okay? This tiny little thing dumping into this huge thing that should be no problem, right? Blood should be escaping, no big deal. Okay, what are they going to complain of? More of that dull ache. Remember what I talked about with the hydrocele? Just the weight of the mass of that fluid, just irritating there, like literally tugging on that nerve in this rheumatic cord and causing that sort of dull, achy, groin, lower abdominal pain. And that's really what it is. It's bothersome to the patients. Even the varicocele, other than what it can do as far as infertility issues, it is benign, and it's almost an entirely benign thing itself, right? The varicocele itself is benign, other than the fact that it can cause infertility issues. And if that doesn't matter to your patient, that doesn't matter at all. See what I mean? So we have to make sure that there's no retroperitoneal mass, make sure this patient doesn't have any desire to achieve fertility, and then from there, take it from there. So do we just treat it symptomatically, or do we refer on? So it's a decision that we make based on the patient in front of us. Okay? But again, when you start to think of reasons for infertility in a male patient, this should come to the top of your mind. Okay? Because it's easy to rule out and it's easy to treat. I actually have a patient story that I was leaving Hawaii, and one of the captains there came, and him and his wife were having trouble achieving pregnancy, and they've been trying for a while. And he asked, I'm just going to tell you guys this, he asked me to look at his old man ball. And so I did a physical exam, and he had the largest varicocele I've ever seen. All right, it's like a bag of snakes. Right? And I'm like, dude, why did you wait to come see me for this? And he's like, well, I don't know, about whatever, shit people say, it's nonsense. I'm like, all right, man, no problem. So we sent him on to the urologist, they fix it, and they had twins. So, you're welcome. So, but anyway, very simple thing, easy to fix. Return of fertility, somatogenesis happens normally, and there you go. All right, so you can affect a real change for your patients by a very simple physical examination, okay? So again, bag of worms should increase with Valsalva. Again, if you're putting pressure, intra-abdominal pressure, you're going to squeeze those veins. So one, it should grow in size so that if you have a very, very small varicocele that you can't even really appreciate, but the symptoms are really consistent with it, then you might be able to manifest it in clinic and then identify it, all right? What do you think ultimately we're going to get? An ultrasound. For any of it, right? Left, right, middle, who cares? We're getting an ultrasound, all right? Middle, yeah, I know, right? That was a joke. So, this is another alarm sign here, okay? Should decrease when the patient lays down. Gravity is our friend, right? If it's just an obstruction to blood flow for an idiopathic reason, then when they lay down, it should get smaller, right? If it doesn't, what might that mean? A mass effect, right? Something is still pushing on it, regardless of if they're supine or upright. Does that make sense? So when they're upright, should get bigger, gravity. When they lay down, should get smaller, gravity. If it doesn't, then that's sort of an alarm sign that we need to get that CT scan and see if there's anything in there, okay? You don't have to know gradations, but, small to large, okay? Doesn't matter. So, we We talked about this one, unilateral right side. Everybody understands that, right? Lesions that remain dilated while supine, meaning they don't get smaller when the patient lays down. That's another alarm sign, whether it's on the left or on the right. Okay? And then the other one is this, something that occurs pretty abruptly or enlarges rapidly. So the patient is normal, and all of a sudden, within a couple weeks or even maybe a month or two, they have this huge varicocele. And again, what does that probably mean? Mass. Some sort of mass has grown and is obstructing the blood flow suddenly. These don't typically develop like that. It takes a while for them to get bigger and bigger and bigger. They might manifest symptoms again without it even being clinically obvious. So if it comes on really fast, really large, then that's another warning sign. Okay, so all of this means this, right? Any of those warning signs, CT scan in addition to your ultrasound. Okay, ultrasound for everybody, no matter what side it's on, whether it's left, right, bilateral. But if it's unilateral, right, or any of these other two, then you would get a CT scan as well. Okay? Does that make sense, everybody? All right. Conservative care is going to be our first line. Again, if it's infertility related, then we would be more apt to earlier referral, right? Because it's not going to get better with watchful waiting. It's not going to regress with medical therapy. It's only going to regress with a surgical fix. So that would be our indication for a more rapid referral to urology. In regular run-of-the-mill patients who are not having that issue, just having the symptoms of a varicocele, again, it's the same thing as a hydrocele. Scrotal support, meaning tight underwear, NSAIDs, profile in this case, because oftentimes running, so activity modification for a civilian, profile for military, of course, and then Tylenol, Motrin, whatever helps your patient. If they don't get better, then on to surgical referral, okay? Because really there's nothing else. There's these treatments, so there's just these sort of symptomatic care treatments, and then there's surgery. There's no middle ground, okay? Does that make sense, everybody? All right. Any questions about varicoceles? We got the gist? We got the important points? Okay. It's going to be right there staring at you. A couple of you are going to miss it. You're going to be upset. So don't prove me wrong. I want you to prove. I want it to be 100% question because I don't want you to miss this in clinic. All right. Hernias, real quick, because you cover it in surgery. This is not a urological problem. This is a surgery, a gen surge problem. Okay, but the same. Remember the pathway I talked about with the hydrocele, where the peritoneal fluid can make its way down. Intestinal contents can do the same. So if you have an indirect hernia, you might be able to appreciate bowel sounds in the scrotum. It's a gee whiz thing for you, especially if it's a large one. And they can be amazingly large. You'd be surprised some of the patients show up in these hernias. But again, same thing of what have you been waiting for? All right. So that's it. Direct hernia is a direct protrusion. Indirect, right? This is bowel. This is testicle. They don't belong together. And then refer to general surgery. That's all I'm going to. That was the talk about hernias. Don't worry too much about hernia. Testicular masses. Okay. Again, we're just hammering the same thing. The epididymal head cyst, the spermatocele, the hydrocele, whatever it is, just send the patient to get an ultrasound. Okay. No matter how sure you are that it's nothing, just be 100% sure, okay? Any questions about the masses, any of the dash seals, any of that stuff, no? Okay. So acute scrotum, why do I have it written like that? Because that's what urologists refer to it as. Remember, you've heard the term acute abdomen, something that has a surgical abdomen. This is something that would be a surgical scrotum. Most of the time, what does that mean? It means testicular torsion, okay? So let's talk about it. So, testicular torsion, this is another thymus tissue, this is another emergency, okay? This is something that is going to go from ischemia to necrosis. You've heard the term thymus tissue, I imagine? I said it 3 times in here, so I know you've heard it anyway. All right. But, what happens? Torsion, okay? Turns on itself, and then spins up. High riding testicle, usually sometimes form, usually the testes will lie in this plane here. If you have a testicular torsion, you might find one laying in the other plane, okay? And then look, I go back to this, and I've had students point this out, irreversible there at 12 hours of ischemia. It doesn't give you 12 hours to play with, okay? And I mean that, like, so why, because I've had that legitimate question. If it's 12 hours, why is it an emergency? Well, one, that is an estimate. And two, it's an emergency because it is a tissue, it is a limb-threatening injury. You understand? It's a tourniquet effect to a organ in their body. It is an emergency, all right? It just means that it's not going to start dying immediately. It's not like a heart attack where the myocardium starts to die like really, really soon after the event. You have a little bit more time, especially if there is some blood flow, because a lot of times it won't be completely occluded. You might have some blood flow, but insufficient blood flow and insufficient venous return to maintain adequate perfusion to the tissue. But that doesn't mean it's not an emergency. You get what I'm saying? Okay. So you can have this, it can be so innocuous. I had a patient that was having a bowel movement, bared down, testicular torsion, came into the aid station. He wiped first, which I appreciate. And he came into the aid station all hunched over. But this is not one of those things. This is one of the things that usually reads the textbooks. This doesn't hide. Testicular torsion isn't typically an equivocal diagnosis. When we talk about exquisite pain, sudden onset of acute tenderness, acute pain, this is one of those definitions, right? This patient is bent over, oftentimes almost universally nauseous, oftentimes vomiting, and excruciating pain, okay? So this is a pretty obvious clinical diagnosis. High riding testes, long acid, transversely. Like I said, goes from here to the one that is spun is like this, sort of now, okay? You can also have this associated with what's called a bell clapper deformity, meaning your patient has their normal anatomy where they have one testes in a different plane because of inadequate fixation of the tunica vaginalis, I think, again. But either way, that patient is more predisposed to have testicular torsion because it's already in this plane. It's more likely just in the typical daily routine to spin. Now, everybody does know that one testes typically is lower and hangs lower than the other, right? And you know why? It's so they don't bang into each other. And that's literally the truth, right? So don't confuse that. And again, it is not equivocal. Like you will, if you're doing an exam on a patient that's sitting there talking to you normally and they have one testes higher than the other, that's their normal anatomic state. They will not be quiet about it if it was a torsion, all right? Does that make sense, everybody? So just expect that when you do a routine physical exam, one testes will be higher than the other, all right? Profound testicular swelling. Remember I had mentioned a reactive hydrocele? A lot of times you will have a reactive hydrocele as fluid starts to accumulate in an inflammatory process around this torsion testicle, okay? This is the bell clapper deformity I mentioned, right? So in addition to this being a pathologic finding that you usually find with a torsed testicle, some of your patients will have this as their normal anatomic state, okay? So they are just more predisposed to having testicular torsion, but it doesn't necessarily mean anything needs to be done about it. So this doesn't indicate a referral. Like if you're confused or if you're concerned, call the urologist, say, hey, I've got this guy who has this, what should I do? Maybe they want to see him, maybe not, all right? Just understand that if you do see that on a physical exam, it can be normal and it can be that this patient has a higher risk of torsing in the future, okay? So, talk about two signs, right? Cremasteric reflex is the one, okay? Prain sign is, you can't really do anything definitively with Prain sign. And I'll explain both from here in a minute. But cremasteric reflex, why would the cremasteric reflex be absent on the torsion? It's already spun, right? Right? So the muscle is in a knot already. So when it flexes, it doesn't go anywhere. It has no more movement, right? So it's already spun. So if you do the cremasteric reflex on that side and it's absent, that is another definitive sign of torsion. Prain sign Elevation of the scrotum fails to relieve pain or might actually increase pain. All right, so if you actually literally elevate the testicles, if somebody has epididymitis, it will relieve their pain because, again, in epididymitis, you just have this inflamed, swollen, infected testicle and potentially epididymis. More of the same physiology, it just hurts when that patient, just the weight of it hurts, irritates the nerve, so when you lift the testicles, it relieves that pain. But in a torsion, essentially what you're doing when you elevate the testicles is just smushing that spermatic cord more, so it makes the pain worse. Okay? Again, praying sign is not something that you can sort of reliably diagnose anything with. Okay? But you'll hear it, and that's what it is. But cremasteric reflex is the definitive sign. All right. Color Doppler ultrasound, we need to see if there's any flow to this testicle whatsoever. Don't let lack of access to ultrasound delay treatment and care, right? So what this patient needs is to get to urology. If you have ultrasound, get it. But the first call you should be making is to urology. Okay? Does that make sense? Don't delay care, right? Just like you wouldn't delay care for a CT scan if a patient has appendicitis, right? Don't let your patients die in a CT scanner. You've heard that, I'm sure. So again, it is a limb-threatening emergency. And so what will happen is orchiopexy, bilateral orchiopexy, because if the patient has torsion in one testicle, they are at risk to have torsion in the other. And if they're already undergoing surgery, what they do is just fix both testicles. When I say orchiopexy, what I mean is they sew the covering of the testicle to the interior wall of the scrotum, literally fixing it in place so that it can't spin anymore. And that solves the problem. All right, that is the definitive treatment. Does that make sense? So both sides. So manual detorsion, if you have a delay in care or you won't be able to get into care, you can try this, all right? And so if I am facing my patient, they call it an open book, so I'm opening the book like this, so I'm turning towards their legs, turning towards the thighs. Don't do them both at the same time or you're going to make the other side worse. Just don't be doing like this. It's not, you know what I mean? No, nothing? You guys, nothing? All right, so, but even if you are successful with this, which you rarely are, it still requires surgery. All right, so what do we define success? Return to a lower normal position, relief of pain. Okay, but I tell you, even if you have it, it's so aggravated that when that patient coughs, if they have an accident, if they sneeze, if they move funny, it's likely to go right back where it was. All right, so this is not definitive care, but go ahead and try it because and like I said, the open book is in general because they usually turn in, so spin them out. But if you're making it worse, then you can try the other way. Like if pain is getting worse, you can try going the other way. You're not, torsion is torsion, so just try your best. But again, it's not likely to be definitively successful, and even if you are able to get it down, the patient feels totally better, they still need to go to get the surgery. All right? Anybody here seen torsion? Yep. What'd you say? What's your experience?
It was after like a 12-mile run. We were sitting out there and he like wobbled up, and the manual thing actually worked. But we still went and got us there.
Yeah.
So it was after like a 12-mile run. So that.
Yeah, I mean that's usually what it is after some kind of vigorous exercise like that. So just give it a try. And again, the indicators of success are very simple clinical signs: return to normal position, relief of pain. But as he said, as I've said, still needs surgery. Okay, questions about torsion? All right. Excuse me, sorry. We're almost to the end, you guys. Epididymitis, epididymal orchitis. Okay, one is an inflammation and an infection of the epididymis. The other one is an inflammation in the epididymis and the contiguous testicle. All right. So in epididymitis, you have a swollen, tender epididymis, but the testicle is relatively normal. In orchitis, you have swelling of the testicle and the epididymis. Okay? Usually, we are concerned about sexually transmitted disease, especially. And when you guys were in IB or in Pharm, did you talk about sort of the STI, less than 35-year-old, greater than 35-year-old sort of empirical treatment? So less than 35, we sort of identify as more likely to be an STI, so empirically treat that. Over 35, we think more maybe enteric organisms, so we empirically treat on the other side. Now, of course, what helps inform that decision?
History.
A sexual history, exactly. Take a good patient sexual history and ask about intercourse and type of intercourse they participate in, okay? Because older people, and 35 is not old. I don't know where the 35 came from. Epidemiologically, that's like seems pretty young, but old people still have sex, okay? Young people can still have enteric organism invasion. So understand what the risk factors are and ask the appropriate questions so that you can give the appropriate treatment, okay? Usually acute, this is an acute presentation. The patient has a sudden-ish, like now when I say sudden-ish, like over the course of a day or two, without having an acute upswing in pain and tenderness. Usually you also have redness of the associated scrotal skin, tenderness to palpation, okay? And if it is STI in nature, often if it's an enteric in nature, you'll have urethral discharge present as well, okay? Irritate avoiding symptoms, so sort of kind of associated with the urethritis as well. And then this patient, because again, just the irritation of that genital femoral nerve, that nerve that's there with that weight of the infection, they'll often have abdominal pain. Sometimes they'll have nausea and association as well, okay? So commonly listed as a differential diagnosis from torsion, but really, clinically, they're very dissimilar. All right, it's just sort of the acute onset of testicular pain that kind of puts them in the same realm. Okay, but other than that, they're really not alike at all. Okay. Crane sign again positive here. So you relieve that irritation of the nerve by lifting the scrotum. The patient feels better. That's not exceptionally useful diagnostic information, but you'll hear about crane sinus, so I talk about it in here. Physical exam. Okay. Now I've been meaning to remove this for so long. Okay, clear enough? Get rid of that equivocal exam. Get an ultrasound. Okay, get an ultrasound because we're going to define this as a testicular mass. All right, and it can confound your exam because it's tender, it's painful, it's irritated, it's swollen. So just get an exam, make sure there's nothing else. Just get the ultrasound, okay? And you guys know what that is, right? Nucleic acid amplification test. Get your STI test. All right. And if there are urethral discharge, present, you can culture that as well to see if it is an enteric organism. So again, you guys know treatment for GC. So that's what this is on the STI side. Remember, this is just epidemiology here. I don't ever like to hang my hat on ages like that. Ask the question, look for the sexual history, and treat the patient appropriately based on their risk factors. Okay? And then on the other side, as I said here, we're going to rely a lot on our fluoroquinolones for our prostate stuff and our male treatment on this sort of GU infection side. So in a non-STI, if it's an enteric organism suspected, then we'll go with fluoroquinolone. All right. And then everybody, it's the same symptomatic care. Again, it's that same hydrocele, varicocele, spermatocele. This, rest, scrotal support, ice, NSAIDs, Tylenol. Okay, symptomatic care. We are almost done. Trauma, okay, skateboarders, straddle injury. It's possible to break your testicle, all right, and then it needs microsurgical fix to put it back together. All right, you can get a hematocele too, with traumatic, with the trauma, you can get a hematoseal. Right? Torsion of the appendix testes, just a quick gee whiz. Blue dot sign. Usually we'll see this in pediatric patients. What you'll have is like a sort of slight irritation. And what has happened is that little tiny appendix has just spun on itself, but it is not an emergency, even though it's got the word torsion in it. It's something that's just, that little piece will just eventually die and fall off, and it's not a big deal. And so essentially, just symptomatic care. Okay, so even though it has torsion in the name, it is not an emergency like a testicular torsion. Okay. Miscellaneous, don't forget our referred pattern of pain. We talked about that in Stones, right? Referral to the ipsilateral. So that patient may come in complaining of testicular pain, whereas the etiology actually is kidney stone, okay? Mumps, because extinct diseases are back, you guys. So, I mean, I learned about measles, mumps, rubella as extinct. It was like a history class in ID when I was in school. And now there's German measles in San Antonio. There's regular measles all over in Texas. So you guys might see mumps orchitis. All right, so think about it and think about your vaccination. Ask about your vaccination statuses. Okay. And foreigners gangrene is a dermatological problem, and I don't really need to talk about it in this. It's a diabetic problem. You've heard any of the diabetic medications say, if you develop unusual pain and swelling in your perineum, go see your doctor. Well, I don't really need to talk about it here other than I like to show this picture. So it's necrotizing gangrene in the perineum. Again, it's not a urological problem, so there's really no reason for this picture to be in here other than that reaction. So post-vasectomy pain syndrome, your patients, again, as the seminal fluid escapes, it can cause a foreign body sensation, a foreign body pain. So in the immediate aftermath of a vasectomy, the patient might experience this. Typically that regresses and goes away on its own. If it becomes chronic, you can refer them back to urology. But in a primary care, like if they come to you after their vasectomy saying they're in a lot of pain, it's just more of the conservative care that we've talked about over and over again, just NSAIDs and ice and support. And then unfortunately, there are some poor souls that just have chronic testicular pain with no organic etiology, and that's called chronic orcalgia. Okay? Any questions, you guys? All right, see you.